if you can hear me, can you squeeze my hand? No response. Hey, Jen, I want to check your eyes. Can you open your eyes and look at me? No response. Hey, Jen, I do need to check your eyes. I'm just going to kind of help you open them by gently opening your eyelid, okay? And when I pulled back her eyelids, she still had nystagmus, which is when the eyes are moving back and forth side to side. I said, guys, I think she's still seizing. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Hello, and welcome back to the Rapid Response RN podcast. November is Epilepsy Awareness Month, so I thought it might be fitting to do a deep dive into status epilepticus, a critical emergency that every nurse needs to be ready to recognize and respond to, especially in acute care settings. So status epilepticus is an event that demands our full attention, quick action, and a solid understanding. So let's break down everything you need to know about it, from recognizing its signs to providing evidence-based care that could save a patient's life. But first, let me share a case that will set us up to talk about the intricacies of managing a patient in status. So I responded to a rapid response call, and when I arrived, the patient was laying in the bed, completely still. The nurse had just gotten a fresh set of vital signs, and at a quick glance at the vital signs machine, they were all stable and within normal limits. The nurse explained that the patient had had a seizure, and they had already given the previously ordered PRN 1 milligram of Ativan, and the seizure had stopped, and now she's post-ictal. I asked about how long the seizure had lasted, and she said maybe 3 or 4 minutes, just as long as it took me to run and get the Ativan from the Pyxis. The family was with the patient, and they're the ones that saw the seizure and called for us, so it's not like she was seizing without anyone knowing about it. They witnessed its onset. So at this point, the hospitalist and the ICU residents who respond to rapid response calls arrived at the same time. And since the seizure had appeared to be stopped, the ICU team returned to the ICU, leaving me with the hospitalist to manage the patient from here. So I went to assess the patient, assuming she was just post-ictal, as she did appear that way from a distance. I addressed the patient. I'll call her Jen, though that's not her name. I never use real patient names or other patient identifiers in this podcast. So went up to her ear. Hi, Jen. I'm Sarah. I'm the rapid response nurse. It looks like you've had a seizure. Your nurse has already given you a medication for seizures, which might make you feel sleepy, but your vital signs all look good and you are safe. We're going to keep monitoring you until you wake up fully. But if you can hear me, can you squeeze my hand? No response. Hey, Jen, I want to check your eyes. Can you open your eyes and look at me? No response. Hey, Jen, I do need to check your eyes. I'm just going to kind of help you open them by gently opening your eyelid, okay? And when I pulled back her eyelids, she still had nystagmus, which is when the eyes are moving back and forth side to side. I said, guys, I think she's still seizing. The doctor said, you can give her another milligram of Ativan. And the nurse left a bullet from the Pyxis. I replied, this is technically status epilepticus. Either she's had 2 consecutive seizures within the last 5 minutes, or she is still in her first seizure that never fully resolved, and we just thought that she was post-ictal. Could we do 4 milligrams of Ativan? The doctor responded, I don't want to give her that many benzos on a med-surg floor. So I politely responded, I will stay with her and monitor her until she returns to her baseline, or we can just move her to the ICU. But the longer we take getting her out of status epilepticus, the harder it will be to get her out and the more at risk for brain damage that she has. So he consented to 2 milligrams of Ativan. We gave it, and she was still having a seizure. At that point, I called the intensivist from the ICU. He answered, and I said, "Hey, doc, I have a patient who's received a total of 3 milligrams of Ativan, and she is still seizing. Could I get a verbal order for 4 milligrams of Ativan to get her out of this seizure?" He asked, "How long has she been seizing?" I responded, "At this point, I'd estimate about 10 minutes. He said, "Oh, yes, give 4 milligrams. I'm on the way with the ICU pharmacist. We can get her loaded with Keppra, and just so you know, Sarah, we may have to intubate." So I gave the 4 milligrams of Ativan and started setting up for intubation. While I was doing it, I was explaining to the family what was happening, and they shared that this had actually happened twice before. This would be her 3rd time being intubated for seizures. Our intensivist and pharmacist arrived just a couple minutes later, and she was still seizing. We loaded her with Keppra, gave another 4 milligrams of Ativan, totaling now 11 milligrams, and she was still seizing. We decided to go ahead and intubate so that we could give her propofol. The doctor wanted to give ketamine as his induction agent, but since we're on the med-surg floor, that medication's not easily accessible, at least at my hospital. And we'd have to go back to the ICU or have a pharmacist run to the main pharmacy to retrieve it, and we didn't have that kind of time. So we gave what we had readily available, which was fentanyl, etomidate, and vecuronium. I know, not my preferred agents either, but sometimes you have to make work with what you have. So I called the ICU charge and have her run me a bottle of propofol while we're getting the intubation going. I optimized the patient's blood pressure with the fluid bolus because she was otherwise young and healthy. We successfully got the ET tube in and started the propofol, and finally, her nystagmus stopped. I took her to the ICU where the EEG tech met us there, and they put her on continuous EEG monitoring. Moral of the story, not every seizure needs benzos. Some resolve on their own. But when a seizure has been going on for longer than a couple of minutes, go big with your Ativan dose, because the longer we take to halt that seizure activity, the more resistant to therapy that the brain becomes. So there's so much to talk about, but let's start with the basics. What is status epilepticus? Well, it's defined as a continuous seizure lasting longer than 5 minutes or 2 or more seizures back-to-back without the patient returning to their neurological baseline in between episodes. This isn't your typical 1-minute tonic-clonic seizure that resolves on its own. Status epilepticus is a medical emergency. It puts the patient at risk for brain damage, organ failure, and even death if it's not controlled quickly. Now, to understand what's happening in the brain in status epilepticus, we need to think of seizure activity as an electrical storm, but in the brain. In normal circumstances, our brain has this delicate balance of excitatory and inhibitory neurotransmitters that keep things in check. But in a seizure, there's a breakdown in this balance. Specifically, there's either too much excitatory neurotransmitter, primarily from glutamate, or too little inhibitory control, which is where GABA comes in. In status epilepticus, the storm doesn't just hit and leave, it lingers, firing across multiple neural circuits, exhausting glucose stores, and pushing the brain into a state of metabolic crisis. So, our goal as nurses is to interrupt that storm as fast as possible and prevent permanent damage. And the first step is recognition. So, when you notice that seizure-like activity, you'll want to keep an eye on the time. If the seizure lasts more than 5 minutes, that's your cue to start thinking about status epilepticus interventions. And if you see repeated seizures without any return to baseline between them, that's the other indicator. It's crucial to note the type of movements, awareness level, and whether there's cyanosis or labored breathing. Remember, timing's everything. Longer seizures means higher risk for complications. So take note of the time. Maybe write it on the whiteboard or on your arm to remember so we can keep track of when this whole thing started. When a seizure persists past 5 minutes, we want to start considering interventions immediately. I like to use the ABCDEFG mnemonic to prioritize my initial responses. Hey guys, I'll get back to the show in just 1 second, but before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show. So A is for airway. We all know this. Get the patient into a lateral decubitus or side-lying position to protect their airway and reduce aspiration risk. Make sure you have suction set up and ready in case they start to have some emesis or excessive oral secretions. B is for breathing. Seizures are notorious for causing apnea or irregular breathing patterns. Often a non-rebreather mask or supplemental oxygen might be needed, especially if there's some circumoral cyanosis going on. If the patient's tonic-clonic seizure activity is so severe that it's difficult to get the mask to stay on their face, you can just jack the flow up on your non-rebreather to flush on the wall, so max it out, and have someone kind of hold the non-rebreather mask close to the patient's mouth and track their movements with the seizure so that mask can provide kind of like blow-by-ish supplemental oxygen. C is for circulation. Now, very rarely does a patient go pulseless from a seizure, but we still want to monitor circulation, or better said, perfusion. Prolonged seizures can affect cardiovascular stability. So keep circulation in mind, watching the patient's skin, know that you might need access to the circulatory system, meaning an IV to give medications. Sometimes that's tough to do because of the seizure activity. So you can also consider alternative routes like intramuscular, per rectum, intranasal, or for life-saving interventions, maybe even IO. And the DEFG is don't ever forget glucose. Low blood glucose can actually worsen seizures or even be the cause of the seizure in the first place. So grab a quick blood glucose reading. Even if, say, you already had one before the seizure or EMS brought you one when the seizure started, glucose can drop rapidly. There is so much metabolic demand, especially in a prolonged seizure. So repeat glucose checks are necessary, and sometimes the patient's going to need some dextrose. Okay, so to review, A for airway, B for breathing, C for circulation, and DEFG is don't ever forget the glucose. Once you've stabilized the airway, breathing, and circulation, it's time to jump into medications. And this is where guidelines come in handy. Benzodiazepines are the first line treatment. We're talking Ativan or lorazepam, 4 milligrams IV. That is the gold standard if you have an IV in place. Studies have shown that 4 milligrams gives us a better chance of aborting the seizure than 1 or 2 milligrams because higher doses reach therapeutic levels faster. If an IV access just isn't an option for this patient, which happens a lot with seizing patients, we have alternatives. Versed or midazolam, 10 milligrams IM or intranasal is another good choice, especially for EMS or pre-hospital settings. Versed kicks in quickly, and studies have confirmed its effectiveness when Ativan just isn't an option. And quick note for nurses, underdosing is a common issue. There's just a lot of fear about respiratory depression with benzos, and understandably so. But when it comes to this patient population, the data shows that treating seizures inadequately actually carries more risk for respiratory issues than giving a full effective dose. So don't be afraid to go big with the recommended dose. Once the seizure is controlled, then our focus shifts to preventing reoccurrence. We're looking at anti-epileptic drugs, or AEDs, like Keppra or phenytoin or valproate. These drugs stabilize the patient longer term and are given as loading doses to keep the brain at a therapeutic level of inhibition. Current evidence shows there's no clear winner when it comes to which AED is better. And Keppra, phenytoin, valproate, they all compare in efficacy. So it really depends on what your facility's protocol is, what your availability is. Keppra is often preferred because of its broad safety profile, but the choice may vary based on each patient's needs and the hospital formulary. As nurses, our responsibility doesn't end once the meds are in. Status epilepticus can have multiple potential causes and complications. So, while we stabilize the patient, we also need to think about underlying causes, like what caused them to seize in the first place. Electrolyte abnormalities, infections, toxicologic factors. You have to think about hypoglycemia, like I mentioned earlier, or maybe the patient's hyponatremic or hypoxic. These can all be checked or addressed as a part of the treatment plan. As far as vital signs, watch the airway and the breathing patterns closely, especially after the benzos are given, because we know they can cause respiratory depression. Check the blood pressure. Patients who seize for long periods could have hypertension due to increased intracranial pressure or that stress response. We want to make sure that we're vigilant and watching for any signs of hypoperfusion. And also, there's so many other potential causes for seizures, like hypertensive encephalopathy or eclampsia or some sort of space-occupying lesion. These are causes where you want to advocate for further imaging, labs, or maybe a specialist consultation. So, status epilepticus is a heavy lift, both for the patient and for the healthcare team. It's an event that requires rapid, coordinated action, strong assessment skills, and sometimes stepping out of our comfort zones with medication dosages to truly prevent long-term damage. The nurse's role is essential because we're often the ones continuously monitoring, communicating with families, and thinking ahead about possible causes or complications. So, the next time you're faced with a patient in status epilepticus, remember your ABCDEFGs and don't skimp on the benzo dose, and keep thinking critically about all the possible contributors and complications. Remember that seizures aren't always tonic-clonic. Some seizures present subclinical, where the only symptom might be very mild, small rhythmic movement of one finger, or nystagmus, or lateral eye deviation. Don't assume, like we all did, that a still, quiet patient is postictal. Don't be afraid to advocate for an appropriate dose to halt the seizures. I hope this episode has given you confidence and clarity on managing status epilepticus. Tune in next time where we're talking about psychogenic, non-epileptic seizures, what used to be called pseudo-seizures. Managing these patients can be a challenge in a different way because there's not actually a medical emergency happening. But learning to distinguish between a true epileptic seizure and one that is psychogenic in its etiology can be difficult. This patient population tends to stir up a lot of opinions and emotions in the nursing community. So I can't wait to explore it more with you. Till next time, folks. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.